It's easy to think that these really complex medical setups are pretty recent things, but sometimes the groundwork gets laid way earlier than you'd expect. Take multi-specialty cardiovascular centers, where different experts work together on heart and vascular stuff. That whole idea, it actually started taking shape back in World War II. Pretty amazing, right?
It really is. Yeah, quite remarkable that even with everything going on during the war, they saw the need for a coordinated, multidisciplinary way to handle vascular injuries. So today, we're doing a deep dive into how these multi-specialty cardiovascular centers came about and how they actually operate. Our sources for this are chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, which really digs into how these practices developed.
Exactly. And for you, the learner, if you want to get a solid handle on the key ideas without drowning in all the details, that's our mission today. We want to unpack why these centers are so important, how they work, the hurdles they face, and where things seem to be heading. We're pulling out the core insights from these chapters for you. Okay, so let's start at the beginning. Where did this all kick off?
Well, the origins are pretty fascinating. Like you said, back in World War II, you had Elkin and DeBakey dealing with just a huge number of vascular injuries. Their answer was to create these centralized vascular centers. And what's really interesting is why they did it. It wasn't just about handling more patients. It was about being more efficient, saving on equipment, people, effort. Centralizing helped. And they also saw pretty early on the chance to gather lots of data, which was crucial for really understanding these injuries better.
Right, and that first center, the one at Ashford General Hospital in 43, the team sounds surprisingly modern. You had your surgeons, obviously, but also assistant surgeons, medical officers, a cardiologist, even a physiotherapist, and someone focused on rehab. That's that's quite holistic, even now. So, okay, they brought them together. But what specifically about that setup made it more efficient? What was the mechanism?
That's a good point. Having everyone in the same place working towards the same goal just naturally smooth things out. Information could flow faster, right? Fewer delays in getting diagnoses, planning treatments. Specialists could just, talk to each other easily. That led to more complete, efficient care plans. Plus, cooling resources, equipment, staff meant they weren't duplicating things. They could maximize what they had.
Yeah, that makes a lot of sense. Okay, fast forward to now. Thankfully, no wartime levels of trauma, but the healthcare world is, it's arguably even more complex. We're dealing with layers of regulations, constant changes in how things get paid for, growing demands for quality and transparency, and definitely, competition between different specialties.
Exactly. Which leads us nicely to a more recent example, the Mayo Vascular Center, started back in 1987. And here's a key thing they realized. Mayo saw that having vascular diagnosis and treatment scattered across different departments, different buildings even, was just inefficient, especially as they were getting referrals from all over the country.
And what seems really smart about the Mayo approach was their vision. They wanted that one-stop patient experience, and they deliberately opened the doors to all the relevant specialties. So it wasn't just about convenience, was it? What's the deeper insight there about focusing on the patient, driving efficiency, maybe even better results?
Well, by putting everything together, making it easier for patients to get all the care they needed in one spot, they cut down on the hassle and the delays of navigating a fragmented system. That boosted patient satisfaction, which we now know is like a really key part of quality care. And by bringing all the specialties in from the start, they built this collaborative atmosphere that could lead to better, more integrated treatment plans. Recognizing those potential turf wars early, that was pretty strategic too.
And the sources note that, at first, private systems struggled to copy the Mayo model. Their structures were just different. But the shift away from fee-for-service through the HMO phase, health maintenance organizations, for you, the learner, and now towards value-based care, that's really changed the game, hasn't it? It's opened the door for different kinds of centers.
Okay, that gives us a good grounding in the history. Now let's dive into the big forces shaping these centers today. Well, number one is the sheer cost of U.S. healthcare. It's huge. There's enormous pressure, especially for Medicare and Medicaid, to find efficiencies. At the same time, we've got an aging population. That means more people needing cardiovascular care. And here's a really critical piece. We're looking at a potential shortage of specialists.
The numbers really drive that home. The reading mentioned about 3,000 vascular surgeons in 2010, maybe only hitting 3,500 by 2040, but the elderly population growing way faster. That means a big jump in things like PAD, peripheral arterial disease. For For you, the learner, that's narrowed arteries, usually in the legs, messing with blood flow. It gets way more common with age. We're talking maybe 20% prevalence by age 80 and estimates of 180 million people with risk factors by 2030. That gap-growing demand, limited specialists, really underlines why we need efficient models like these multidisciplinary centers.
Absolutely. And that combo, the shortage and more PAD, makes these integrated centers seem like, well, the ideal setup for comprehensive care. We're also seeing a big shift in where the care happens. A lot of PAD interventions have moved from inpatient hospital stays to outpatient settings, even seeing a rise in procedures done right in the office.
It feels a bit backward, doesn't it? Medical advances often focus on hospital treatments, but the trend is outpatient. And yet, inpatient costs for PAD and Medicare are still going up. It looks like the money, the financial incentives for outpatient care, prevention, population health, that's probably going to really shape how these CV centers evolve. So with demand rising and fewer specialists, how is care delivery actually changing?
Right.
It's a definite move, right?
Yes, and those financial incentives are a big part of why it's shifting. Then there's competition. We've seen centers pop up focusing on areas that pay well, like CV, orthopedics, neurology, especially outpatient ones. Remember the boom in CABG programs in the 90s? Coronary artery bypass, graft surgery. Suddenly you had lots of new programs near existing ones that can mean duplicated services and potentially worries about results at centers doing fewer procedures.
Right. And even new tech like EVA endovascular aneurysm repair, that less invasive aneurysm fix-it sort of paradoxically fueled competition. Because more places could do EVR, it spread the cases out, even if maybe some centers didn't have the same deep expertise as the high-volume ones. It's a really tangled web.
It really is. And you absolutely can't ignore how reimbursement is changing. Plus this huge focus on care quality. Moving towards pay-for-performance, value-based payments, it's pushing everyone towards using proven practices and focusing on patient satisfaction. And what's interesting is how value itself is being redefined. It's not just about the outcome for one patient anymore. Now it includes their whole experience, how efficient the care was, managing costs, the whole picture.
And we've seen things like Medicare's physician feedback program starting back in '08 and the value-based payment modifier coming up. That kind of transparency linking pay to quality and cost puts real pressure on these centers to deliver genuine value, not just meet metrics.
Okay, so we've got the history and the current pressures. How do these centers actually get set up and run day to day? Well, for a center to work, the health system needs to really think about how patients get to the specialists.
Right.
It's a balancing act, right?
Yeah.
You want convenient outreach clinics, but you can't spread your main site resources too thin. The goal is always right patient, right specialist, right time, cost effectively. That takes good management, like really streamlining scheduling, thinking about patient convenience.
And bringing different specialists together, well, you're bound to have some friction, some interspecialty dynamics to manage. Handling that effectively needs skilled leadership, people with experience, the right temperament, people everyone trusts. You see that dyad or triad model a lot, a doctor leader working closely with an administrator. It highlights needing both clinical and business sense at the top.
Yet, the leadership team needs a whole toolkit. Project management, understanding the big picture strategy and the daily operations, being good with numbers, and knowing the ins and outs of quality care. But maybe the toughest part, getting everyone pulling in the same direction, aligning incentives, making sure everyone shares the same values and expectations, getting that stuff down in writing, informal agreements, absolutely critical.
And it gets even trickier in academic medical centers, right? Because doctors might report to their department and the CV center. That dual reporting can definitely blur the lines of who's responsible for what. Then there's the whole sensitive thing about deciding who gets to do which procedures, especially when different specialties have their own guidelines. It seems like the answer involves setting a high bar, maybe cross-training, and having clear, fair pay systems that everyone buys into.
Integrated finances are also key, especially now that more doctors are employed directly by health systems. You need a dedicated budget, like one single profit and loss statement for the whole CV operation. It helps everyone see the same financial picture. And pay is changing too. It's getting tied more to quality and performance, not just how many procedures you do. Sharing incentives based on how the team or the unit or the whole system performs. That can be a really strong way to get people working together, like maybe incentivizing outreach work, even if it slightly dips someone's individual productivity numbers.
And building that culture of excellence is crucial. Competition for CV patients is fierce. Centers have to stand out based on outcomes, price, how easy it is to get an appointment, reputation, rankings. Getting those top rankings, those desired badges, takes a serious commitment to collecting and analyzing data. And governance, clear responsibility, clear accountability. It's non-negotiable. That dyad model, again, it really speaks to that.
You see different ways to structure the operation, too. Matrix versus integrated models. Each has pros and cons. A matrix might make some decisions faster, but muddy the lines of authority. An integrated structure could be more efficient for decisions, but harder to manage day to day. Really, the structure has to fit the local culture. Academic centers, with their old-school hierarchies, often find it harder to shift to fully integrated models compared to places like Mayo, which move towards patient-centered approaches, partly because of value-based payment pressures.
Yeah, getting specialties integrated into one service line in an AMC. That bumps up against existing power structures, how doctors are trained, internal competition. It's tough. Takes some really skilled leadership to navigate all that. Okay, so that helps understand how they're built. What's the landscape like now? What do these centers typically look like today?
Well, a survey mentioned in the sources found that it's roughly a three-way split. About a third are in academic medical centers, a third in non-teaching community hospitals, and a third in teaching community hospitals. And most of them, the vast majority, are part of bigger health systems. That tells you it takes significant resources to run one of these effectively. It's worth remembering that just setting up a CV center, no matter the type, brings a whole new set of challenges in governance and operations.
And the names they use, service line, center of excellence, institute, they actually mean different things in terms of how integrated they are, right?
Exactly. A service line is often more about administrative coordination, maybe saving costs, encouraging collaboration. Centers of excellence go a bit further, involving more clinical cooperation on things like sharing facilities, coordinating schedules, making referrals smoother. And institutes, that's usually the highest level of integration where they're financially linked, sharing fiscal responsibility.
What drives hospitals to set them up? The motivations seem a bit mixed.
Yeah, administrators often talk about the business side, boosting patient numbers, getting better deals with insurance payers. Physicians often mention patient-centered reasons too, though keeping their specialty referral streams going is still important to them, naturally. What's interesting is that the more integrated centers often had doctors heavily involved early on, with a real primary focus on making patient care better.
And it sounds like most centers have cardiology and vascular surgery at their core. Then other specialties like cardiothoracic surgery or interventional radiology get involved to different degrees. Having a dedicated administrator is pretty common, though what they're responsible for can vary a lot. Same with physician leadership. Could be one director, could be several from different areas.
It's also true that many CD centers are still works in progress, still evolving. Newer ones often start as service lines aligned administratively, but maybe with separate budgets and oversight for each specialty. Clinical stuff might be integrated or it might not be. And like we said, in academic settings, divisions usually still answer to their home departments. Both academic centers and community hospitals can be hesitant to go for fully integrated, disease-focused structures. They worry about losing money from profitable areas or giving up control.
But whatever the structure, it seems most use KPIs, key performance indicators, to track how they're doing. They build scorecards tied to their mission and values, looking at things like market share, how quickly patients move through the system, staff happiness, reintervention rates. And marketing is big, right? Especially where there's lots of competition. Tracking market share is important, but maybe not that effective if the center isn't truly integrated underneath. Okay, that paints a picture of today. What about tomorrow? Where are things headed?
We'll probably see more consolidation. More hospital mergers and acquisitions happening. The goals there are usually to standardize care, cut out waste, improve quality, and lower costs. We're also likely to see even more collaboration between all the specialties treating vascular patients. Maybe credentialing will start looking more at actual experience and skills, not just which specialty someone trained in. Sharing knowledge, spreading best practices, that's going to be huge.
It definitely sounds like these multidisciplinary centers are set up well for where payment is going. Bundled payments, accountable care organizations. Bundled payments push for good clinical results, using evidence, being efficient, and working together because there's one set payment for a whole episode of care. That BPCI initiative, Bundled Payments for Care Improvement, specifically includes cardiovascular diseases.
Exactly. And ACOs, accountable care organizations, zoom out even further. They focus on outcomes for a whole population, rewarding good chronic disease management, prevention, using resources wisely across the community. It's interesting that lower revenue, doctor-led ACOs seem to perform better sometimes. It just shows how different payment models will favor different kinds of setups. You really have to understand the payment landscape, locally and nationally, to succeed.
And we can't forget the patient becoming more of a consumer, right? With higher deductibles, people will shop around looking at online reviews for quality, looking for price transparency, especially for outpatient stuff. We'll probably see those HCA, HPS surveys. For you, the learner, the patient satisfaction surveys extending more into outpatient centers too, and technology, obviously. Patients expect easy access to their records, their imaging. They want convenient online scheduling, more on-demand access.
Yeah, scheduling platforms, physician portals, they'll need upgrades, and we'll likely see more just-in-time approaches to getting patients access to vascular specialists efficiently. At the end of the day, long-term success is going to come down to a few key things: smart, forward-thinking leadership, a real commitment to excellent patient care, proven results and quality, staying on the cutting edge with research and innovation, and having dedicated doctors with access to the best technology.
So the big takeaway seems to be this: the winning CV center of the future. It has to be multidisciplinary, truly patient-focused. It needs to give doctors a real voice in running things, set clear quality standards based on evidence, break down those old specialty silos, and fully embrace collaboration. That seems like the only way to get everyone truly committed to growth and, most importantly, better outcomes for patients.
Which leads us to a final thought for you, the learner. Given how complex payment models are getting and how fast technology is moving, how might the actual definition of a multi-specialty cardiovascular center need to change over the next decade to really maximize value and optimize care for everyone? Something to think about.